Hello and welcome to today's webinar. Thank you for joining us. The focus of today's webinar will be on minimal residual disease quantification of acute lymphoblastic leukemia by high-resolution multicolor flow cytometry. It's with great pleasure that I'm welcoming Dr. Matthias Ritgen, who is the senior physician at the Clinic for Internal Medicine, Hematology and Oncology at the University Clinic of Kiel in Germany. The Hematology department is led by Professor Kneba. This lab has been for more than 30 years a reference lab for the diagnosis of acute and chronic leukemia and myeloblastic syndromes. Dr. Ritgen, who's joining us today, is leading the flow lab in the Hematology department, which is well known for its work around ALL MRD, and also as a reference lab for Germany for ALL MRD. Dr. Ritgen is also a member of the Euroflow Consortium. Before we hear from Dr. Ritgen, I'd like to remind you all that you will have the opportunity to ask some questions. To do so, you can click on the question mark button that you should see on your screens. We all ask that you type down your questions, and we will be answering these at the end of the presentation. So we will have a dedicated Q&A session once Dr. Ritgen has finished his presentation. I am now ready to turn the stage to Dr. Ritgen. I would like to thank him again for giving this presentation, and I now turn the stage over to you.
Yeah, hello everybody, thank you very much for the nice introduction. My name is Matthias Ritgen and I will present you some data on MRD measurement in B-cell precursor acute leukemia and mainly based on flow cytometry. I will give you a short overview on what I would like to present. So I will start with a small introduction on the clinical implications of MRD detection, and then I will switch over to the methodology part with flow cytometry and a small excursus to PCR-based techniques, and then I will go to the MRD measurement by flow in detail, and also gating strategies and some pitfalls and problems which we may encounter in new treatment strategies in B-cell ALL. So clinical implications in BCP ALL is a story of the last few years, and it was driven by actually the childhood ALL groups all over the world, so not only in Europe, but also in the United States and other places. And I've shown here one slide of the BFM ALL group, which has introduced the MRD measurements in childhood ALL. These were mostly PCR-based data, but it's a proof of principle that MRD in childhood acute lymphoblastic leukemia is able to stratify patients into 3 different risk groups. Those with a very good risk group with low MRD at 2 different time points, called time point 1 and time point 2, which is after induction treatment, and those with intermediate MRD and those with very high MRD at both time points. And this is developed further in the last few years, and their time point 1 was at day 33, which is shown here on the right side. And several groups have tried to find earlier time points in the treatment to identify high-risk patients even in the very beginning. And you see here on the left side time points MRD detection at day 15, also in childhood B-ALL. And you can see that early time points with a quite high BCP ALL load have a high relapse rate and a short remission-free duration whereas those with low MRD load, which is just below the cytomorphology cutoff of 1%, have a very good long-term follow-up. And so in this slide, you see that MRD detection was used for development of new treatment strategies. This is a small part of the BFM ALL 2000 trial, and here it was used the MRD detection on day 33 and day 78 to do a randomized trial for reduced delayed intensification, because in the good risk arms we had quite good long-term follow-up, and there was a question whether we could reduce chemotherapy intensification to reach same results. But it was in the follow-up, it was clearly shown that patients who got the reduced chemotherapy dose, here in yellow on the left side, disease-free survival and overall survival was inferior to the standard treatment arm, and this was quite amazingly visible in all genetic and clinical subgroups. And so even with MRD stratified dose reduction, it was clear that those dose reduction was not superior than the standard regimen. So this is another useful tool for the MRD detection. So in summary, we have with the MRD detection a valuable tool for the risk stratification in childhood and adult ALL. I didn't show you any data on adult ALL cases, but this is more or less similar, although the overall results in adult ALL is quite inferior to those in childhood ALL. And I've shown you that early and late time points have impact on outcome, and that MRD cutoff are dependent on the time point and the treatment protocol. So each treatment protocol has its own definition on time points as well as MRD cutoffs, although they are similar in between the different study groups. And I've shown you that MRD is a useful tool to compare treatment efficacy and in your protocols, and helps to identify patients where we can reduce the chemotherapy or even need to increase the treatment protocols. Now I would like to come to some slides for methodology part, and I would like to show you the PCR-based strategies in advance, because this was the beginning in MRD detection in ALL, and this is a slide from the former Biomed group, now the Euro MRD group led by Jacques van Dongen in the later times. And you see that PCR-based MRD detection for immune genes is quite complicated. We have IG genes which are quite heterogeneous spread over the genome and are rearranged during B-cell development to form a unique clone-specific DNA sequence which can be used for follow-up with MRD. So we need to design patient or even clone-specific primers and design a quantitative PCR assay, which is then feasible for the follow-up time points. This is quite a laborsome work because it's starting with clone identification, sequencing, then developing a primer assay, testing for sensitivity and specificity, and then for follow-up. So the setup of the PCR takes several weeks until the validation procedure is done, and has to be done for each patient individually. There are other techniques like RNA-based PCR techniques for fusion genes, but those are only applicable in a minor proportion of patients. Not even 50% of patients show such kind of fusion proteins. So the most commonly valuable tool is the PCR-based MRD detection by immune gene rearrangements. So this is a technique which is highly sensitive and it's stable over time. So the clone is usually stable over the whole course of the disease, and clonal evolution is rather rare. And the DNA is also stable over time. So we can use DNA stored from frozen tissues, or even take blood which is traveling for a week or 10 days by regular mail. And it's more or less quite independent from the treatment used. So the normal background of B cells is influencing rather moderate in terms of sensitivity and specificity. And so this is quite good technology, but it's technically demanding, and only a few laboratories are able to do this in a high quality standard manner. And we need definitely an initial diagnostic sample to identify the specific leukemic clone. And as I said, we need quite some time to develop the assay, and even the follow-up samples take at least a few days until a week or two until the results are available in the clinics. Flow-based MRD detection is different from that. It's not as standardized, I would say. So there are several groups around the world who are working on this. And if you look through all the assays which are published, I show here some markers which share most of the groups. So there are most of B cell markers in the different expression levels, and some aberrant markers, maybe myeloid markers, which might be co-expressed on the leukemic clone. And I think in Europe, quite straightforward is the BFM flow group led by Michael Dvorak, who developed and tried to standardize this technique in the recent years. But also in UK and also in the United States are several groups working on standardization and harmonization procedure on these techniques. And I will go a little bit further into detail into the techniques by flow. But first of all, I would like to show you some data which shows that standardization is very important. In this slide, you see different kinds of lysing protocols used, and the implications on the expression level of different kinds of antigens. So in the upper part, CD19, CD4, and CD8, quite stable and high expressed antigens on normal and even malignant cells. And you see different kind of staining procedures and the time after staining and measurement. So you see that there is, dependent on the methodology, lyse no wash and lyse wash by example, and lyse wash with additional fixation, that the expression levels are influenced by time and by the technology. And this is in the upper part using ammonium chloride lysing procedure, in the lower part the FAX lysing solution. And I think which is most important in this slide is that there's no clear direction in which the different antigens will be influenced by, and that there's an up and down over the time. So you cannot tell which direction it will go, and therefore that standardization is quite important. But moreover, there is an additional influence on the antigen level, and this is the antigen modulation by treatment. So if you look at antigen expression levels, here by example CD10, over time in the treatment protocol. You can see that during the protocol treatment, the expression level of CD10 is decreasing in the early phase, and in the later phase coming up to the regular level again. And this is for each antigen, again, individually a process. So CD34 is also going down and up again, whereas CD20, by example, is an increase in the early time point and then a more or less stable phase. And the Euroflow group has tried to standardize all these procedures, has published some SOPs to set up the different flow cytometers and also the staining procedures to show that if you follow those SOPs, you can generate flow data which are highly stable, and you have comparable data in linear samples over time. So in your lab, a sample measured today, next week, next year shows similar result, or even have very comparable data in between different labs. So on the right side, you see here a multicolor assay in a multi-dimensional plot. And you see that 30 donors measured at 8 centers cluster quite nicely. So each color is one cell group. By example, in red, B cells. And even if this is in 8 different centers, they are clustering very close together. On the right side, you see it in a single donor compared into the 8 centers. And this was the basis for the further Euroflow approach, that flow data can be compared to a reference database to identify malignant diseases compared to a normal database or a database of malignant diseases. So a short summary in between. Up to now, most flow-based MRD assays are compared to PCR-based techniques less standardized. Different study groups use different methodologies and even different platforms. So there are assays published with 4, 6, 8 or more than 8 colors. All of them use quite different staining protocols. They do use different clones or fluorochromes, and there are different gating approaches. And I'm sure there will be, in the future at least, different software approaches to deal the complexity of the multicolor flow data we will see in the next years, because 6 and 8 colors is maybe still doable in the common way of presenting flow data, so in a 2-dimensional plot, but going to 10, 12 or even more color assays is getting more and more demanding, and I think it's not possible to do this without software developments which are coming to the market quite soon. So we have influence of normal background to the flow assay. I will come to this later. We have intersample comparability, which is needed to compare the actual sample to the initial sample, and they are the limitations of the flow assays. So these are the at least European standardization projects. On the left side, the IBFM flow network, and on the right side, the Euroflow group. I think this is quite well known in the community. And this is the example of the Euroflow approach for BCP ALL MRD detection. It's an 8-color assay with 2 tubes. And if you look at the assay, which is quite obvious that there's a quite big backbone of 7 colors common in both tubes, here in red linings. And these backbones are used to identify the normal B cell background and B cell maturation. And in blue, there is the channel for the aberrancies, which most often occur in BCP ALL. So those 4 antigens are included to avoid a tube setting which has to be individualized on the specific case. And if you develop a flow assay, I think it's important to know about the sensitivity and the specificity of this assay, and this was done in the YourFlow group, I think, quite extensively, at least now published recent years ago for the diagnostic samples, and it will be soon for the MRD as well. And so there's the question, what is positive and what is negative, and the false positive and false negative rates, and how many cells are analyzed is a big issue in this aspect, and the background. And this is what I want to go into detail in the next few slides. You see here a trial driven by the group in Prague, and they looked at the number of cells acquired in the flow assay and the influence on the correctness, so the specificity of the assay and the sensitivity of the assay. And on the left side, you can see that the different curves show different time points in the treatment, and the columns are the different numbers of acquired cells with both tubes together. And you can see that the more cells you acquire, you better reach a concordant result with PCR. And on the right side, you see the sensitivity at day 15 and day 33. And also in this aspect, and this is quite clear, I think, the more cells you acquire, the sensitivity increases. And another question which also occurs often is the question, which kind of material has to be analyzed? So this slide is showing the different source of the material, so peripheral blood or bone marrow. And you see in the upper part a comparison of blood and bone marrow. And the left paragraph shows cases of T-ALLs, and there you see quite good correlation between blood and bone marrow, with only a few samples more sensitive in bone marrow than in peripheral blood. But if you look to the very far right side, you see that in BCP ALL, there's a total different story. We have a quite high number of samples which are clearly highly positive in the bone marrow, but negative or very low positive in the peripheral blood. So here's the story quite clear. For BCP ALL, you need to analyze bone marrow, and peripheral blood is definitely not sufficient. These were data analyzed by PCR, but this is the same story in peripheral blood measured by flow. Another thing is whether you have to analyze more than one sample. So in former times, we received left and right side punctures. And here you see that there's a quite nicely correlation. So you don't need to do several punctures of the same patient at the same time point. So in conclusion, we have three different methodologies. We have PCR-based MRD detection, which is suitable in about 90% of cases with a high sensitivity of 0.1% or even 0.01%. And it's technically demanding, as I said, and time-consuming. The question of NGS technology, so next generation sequencing, is still an open question, and I think we have to wait another few years whether this is a technology which will be in addition valuable or maybe substitute PCR or flow. Most data are not mature enough to make a final conclusion right now. There are fusion transcripts. I told you that there's only 50% or not even cases which are suitable. It's a quite rapid technique because the fusion transcripts are known, standardized assay, but they are RNA based and therefore you need fresh material analyzed in rapid time. And the flow cytometry, which is also applicable in above 90% of the cases, have a sensitivity of about 0.01%, maybe with upcoming new flow techniques even deeper. It's, I think, a technique which is developing still, and with growing standardization will be easier to apply. At the moment, I think it's still a methodology which is rather used in specialized labs. And now I would like to come to a more in-depth slides on how we do ALL MRD in BCP ALL. And here you see how we do it. We do in the first instance here on the left side identification of cell debris by scatter characteristics. And here we gate out doublets by the different forward scatter characteristics. And as developed by the BFM group, we have included a cytostaining to exclude non-viable cells. By so clear data, we then gate on B cells detected by CD19 expression, and then we show the different fluorochromes we are staining, which I've shown before, by example, the YoFlow approach or the other approaches, and you then depict the normal B cells against the aberrancies. In this case, it's quite easy because it's a day 15 sample bone marrow puncture of a childhood BCP ALL. And this is easy because at that time point, you barely see any B cell progenitors. So you see here mature B cells with high CD20 expression, low CD10 expression, a quite high CD45 expression. And in contrast, in black, the BCP population, which shows a very high CD10 expression, low CD20, and decreased CD45 expression. In the lower row, you see that there's a B cell, stem cell marker CD34 expression, and an aberrant expression of CD13 or CD33. But not all time points are time point day 15, so we have to know more about B cell regeneration. And here I show you two dot plots of normal B cell regeneration in bone marrow. Again, CD10 against CD20 on the left side. You see here again in dark green the normal mature B cells. And now you see a different picture compared to the slide before. You see here in orange or dark orange B cell hematogones with high CD10 expression and gaining CD20 expression until you reach a level of mature B cells. In the lower left, in light green, is a population of plasma cells or maybe even plasma cell progenitors with missing CD20 expression and missing CD10 expression. And if you look at in CD45 against CD10 plot, you see that also plasma cells have a diminished CD45 expression, and also normal hematogones have a reduced CD45 expression. And if you plot now the development of B cell marker expression over time, you can, on the left side here in a multidimensional plot again, describe different B cell maturation stages over time. Dark green, mature B cells, very light green, early B cell progenitors with, you can't see here, but you know, CD34 expression, CD10 expression, low CD20. And on the right side, you see here immune profile over time in the columns from the left to the right, from very immature to very mature B cells on the right side. And this you have to keep in mind if you look for B cell blasts, because B cell blasts may overlay these normal B cell regeneration. And most important is that the B cell regeneration changes over time. So here you see, again, from the group in Prague, slide which shows the normal B cell regeneration after treatment. So in the first slide on the left side, you see in the outlines, again, in light green to dark green, the normal B cell parts in normal bone marrow. On the left side in light green, the very early one, the dark green, the very late stages. And you see early after treatment, you have almost only very immature B cells. And with ongoing time, the major B cells develop and growing up. And after 1 year of treatment, you have a normal B cell compartment in the bone marrow with almost only mature B cells in dark green circles, and only a few B cell progenitors in the left upper corner here in the light green. And this you have to keep in mind if you analyze MRD samples, because you have to always compare your data to the time point, and you have to know how the normal B cell compartment will look like at the time point you are analyzing. So here again, our normal B cell background. And if I now plot the B cell blast here in dark red against it, you can see that the different plots have different kind of resolution in terms of identifying B cell blast. So if we start from the left side, we have here CD10 against 123. This was identified as an aberrant marker at diagnosis. You can see that even normal B cell progenitors might overlay a little bit with the malignant blasts, whereas here in the 45 against 34 plot, you have a nicely separation of the blast compared to the normal counterparts. And this I like the most. So the CD20 against CD10 plot, you see a nicely development of normal B cells with aberrant B cell blasts. You can see that they have a higher CD10 expression by lower CD20 expression than mature B cells, but higher than early hematocytes. But also the initial ALL immunophenotype you have to take into account. So the slide before, this was a normal common B PCP ALL, which is clearly CD10 positive. And here you see a pro-B with a low CD10 expression. And here you do not have any problem to differ from normal hematocones, because they are always CD10 positive by definition. But you have a problem with the contaminating plasma cells in the same area or same spot as the leukemic blasts. So there might be other markers, by example CD11A or CD34, which may allow a differentiation between plasma cells and malignant leukemic cells. So identifying normal cells in your regenerating blood or bone marrow sample, and all cells you cannot identify as normal, those are most likely blasts. But to do so, you have to analyze normal bone marrow to have your own reference with, if you develop your own assay, your own reference, how normal cells look at different treatment time points. And keep in mind, I said it before, that there might be an antigen shift in different treatment time points. So here, a nice publication from the US group, which looked at CD10 expression over time in treatment. And here you can see the blasts in red, which show a clear decrease in CD10 expression over time, which in later time points increases again. Maybe you remember the earlier slides where this was shown as well. And you can also see that if you look at your dot plots, you may overlay the blasts with the normal counterparts. So take all this into account and not draw your gates where they have been at the diagnostic stage, because then you might miss the malignant clone. And to make it even more complicated, there are other phenomena with which may lead into false negative results. And the major pitfall is a phenomenon of switching ALL. It was first described more or less in parallel from the Michael Dvorak group in Wien and from the colleagues in Prague, that we have some ALLs which show early in the treatment phase a rather shift to a myelog immunophenotype. Here again, a dot plot with normal B cells in green and in red the ALL clone. And if you look at the immunophenotype, you see that the CD19 positive cells show an increase in CD13 and 33 and even a loss of CD19. These are all B-ALL blasts, so the purple one as well as the red ones. And this can nicely be shown by the expression of CD34 in the lower plot. And if you just gate only on CD19 positive cells, you may miss the purple ones. And this is a difference to PCR techniques. The PCR will most likely identify those as blasts as well, because they normally still have the B or T cell receptor rearrangement. Whereas if you just gate on CD19 positive cells, you may miss those in conventional gating. And here you see it in a multi-dimensional plot again, that there's a nicely shift from the normal initial diagnostic clone over an intermediate state to a more or less normal monocytic cell lineage. I think now we come into a phase where we have now more directed or targeted treatments, even in ALL, and this will bring us into new problems in the MID detection, because there are CD19 directed BiTE technologies, by example, or other CD22 directed antibodies. And I want to show you one example here, a CD45 site scatter plot with granulocytes, here erythroid progenitors, normal lymphocytes, monocytes, and here a more or less blast or monocytic population. And if you have a CD19 versus CD45 plot, you see nicely here B cells. And if you look at the immunophenotype, you think, well, this is a normal B cell hematogenes with CD10 expression, gaining CD20 expression, a little bit 34 expression, as you would expect in regeneration. But there are also CD19 negative cells, as shown here, which show a CD22 expression. And this was a patient which was treated by blinatumomab and was downregulation of CD19, and so escaping your normal gating strategy. So if you do an analysis, you have to know the clinical situation the patient is in terms of regeneration and in terms of treatment or directed treatment techniques. So to summarize, I call it ALL escape from MRD quantification. We have an ALL clone, which is a true clone, and you have, by example, a PCR approach, which I showed you can identify about 90% of the clone. And there are rare cases which show even a PCR detected clone shift, so a mutation in the immune gene rearrangement. This may occur. I don't want to go into detail on this. And you have the flow approaches, which from my perspective have a quite high overlay to the PCR detected method, but I think there are also cases which you rather get by PCR or by flow and not by both of them. And there are escape mechanisms from flow MRD by immunophenotypic change, maybe treatment driven. I showed you CD19 negative cases in follow-up, or antigenic shift, like treatment-driven maturation, CD10 loss by treatment over time, or as I showed you just before, the lineage switch phenomenon, which may either be treatment influenced or is it genetically predefined. We don't know yet. And there are several groups working on this to identify which parameters may lead to this phenomenon. So flow MRD is quite a demanding technology, I think. We are coming into a phase where it's more and more widely used with standardized techniques introduced by the Euroflow community, but as well as other groups like the IBFM or also the US groups. We have a good tool with MRD to do risk stratification and clinical protocols. We have PCR and flow in parallel to use. We can quantify in a quite sensitive and specific manner if you take into account all the pitfalls, especially in flow with regeneration and antigenic shift I showed you before. And I think the outlook for the next few years will be that we will be faced with some advanced software tools of identification of maybe even automatic identification of blasts, or at least helping to do a standardized analysis, software analysis. And the first insights, I think, is the automatic gating strategy of some software tools like Infinicide, which is now already on the market for diagnostic samples, and the automatic comparison with reference databases, whether these are your own databases or commercially available, we will see in the future. I hope I have shown you the main topics in MRD detection in BCP-ALL, and you got insight into the pitfalls and the difficulties, at least, especially in flow detection. And I'm happy to meet you for some further questions just after the talk. Thank you very much.
Thank you very much, Dr. Ritgen. I think this was a very nice and comprehensive presentation. We will now move over to the question session. And I just want to remind you all that you have the opportunity to ask questions by clicking on the question mark button. So if you haven't yet had the opportunity, I would encourage you to start asking your questions right now. And before we go to the questions, I actually have a question for you, Dr. Ritgen. And as we can see, it's probably something that's very tricky to set up in a lab because you're analyzing many cells and so on. So what would be kind of, say, your recommendation or your takeaway for a lab who would like to implement this? And also, what would you advise to your peers if they wanted to do this in the labs? And perhaps what were some of your bottlenecks in getting to this?
Yeah, thank you very much. Well, the main problem probably is the amount of cells to be analyzed. So compared to regular flow for immunophenotyping, like immunodeficiencies or so on, you have to acquire a bunch of cells, 5 million or even more per tube. So this takes time, and so your machines are more occupied than you are used to. And you need more or less bulk-lysing procedures to get so many cells into your tube. This is the first point, and if you're not used to these techniques, you have to establish this as well together with the protocol. And then you need to know a good overview of the normal B cell regeneration. So you need normal bone marrow samples. Best under the normal treatment you would have your MRD samples of to know what happens in the bone marrow with the normal B cells. Or you choose a published panel like the Euroflow panels, and I think within the next month there will be databases available for even MRD detection, which you can compare your sample to.
Okay. Thank you. And I do see that we do have a couple of questions coming in, so I will start with the first one. So first of all, we have one which is, how did you determine the limit of detection?
Well, this is done with normal bone marrows in parallel, or even bone marrows which have been taken from treatment. So we do normally cross-lineage assessments. So we try to use T-ALLs under treatment, and we analyze by BMRD panels to see how we would misclassify normal hematogones as B cell blasts. This is the best thing to do. The other things you can do is merging electronical files together with regenerating files, but this is rather just an approximation. And the third method you can do is mixing diagnostic samples together with normal bone marrows in a dilution series to see how deep your sensitivity can go.
Okay, thank you. I do see a lot of questions coming in, so I'm just asking the audience to bear with me, and we will get to their questions. So we are also getting asked, how much would you say is the recommended number of events to be recorded, and of which population?
Well, this is the question on the time point and what kind of sensitivity you would like to reach. There's always a discussion on how big must the MRD population has to be called a population. There's discussion about 20, 25, 50, or even more. So I think at least 25 is a good cutoff as a positive population. And then it depends how deep you would like to go. So for the IBFM trials, the early time points, we would like to gain for a sensitivity of 10 to the -3. So you need at least 200,000 cells or 1 million cells around. But if you want to go a lot deeper, then you have to measure 5 million or even 10 million cells.
Okay, thank you. We're also getting asked, so apart from the CD8, CD19, and CD34, which other markers do you think are the most valuable to distinguish between the regenerating hematogones and the residual blasts?
Well, it's always a combination of parameters. I think there's not a single one, which is also different between different kinds of time points and initial phenotypes. But I think CD58 is a good one. CD10 together with CD20 is always good. CD11A works quite well for some phenotypes at least. And if you identify an aberrancy in the diagnostic sample, this is helpful as well. But especially in this case, you have to know how the modulation will be. So the CD13, CD33 is, I think, a good or more or less stable marker, and CD66C, maybe CD123 works well as well.
Yeah, so this also turns another question which we had around any advice on the use of CD73, CD123, CD304, and CD66C. Yeah. So I think this answers that perfectly. Thank you. So now we're getting many questions around the amount of cells. That's generating a lot of questions. So one, for example, says, well, thanks for the great session. And I want to ask about the protocol to follow when the sample is hypocellular to get to a 5 million count of cells.
Well, what we are doing is we do a bulk lysing procedure, so more or less ammonium chloride-based lysing procedure rather than the lyse washing to concentrate the sample and staining after lysing. Which enables you to increase the cells, but for sure there are in some cases very hypercellular bone marrows which are not able to reach your target sensitivity. This is a problem of the methodology, and this is I think a problem all three methodologies, so flow, conventional real-time PCR, as well as NGS, that we sometimes have samples with too little cells available to reach a sensitivity of 10 to the minus 4 or 5.
Absolutely. And if the sample is diluted, would you still go for as many cells? What's your recommendation?
Diluted with peripheral blood, I guess, is the question. Well, this is a problem, that's true. We look for red cell progenitors or erythroid progenitors in the sample, and if this is at least below 1 or 2% of the sample, we at least given advice that this is a sample which might have been diluted by peripheral blood. This is introduced by the IBFM group, which recommends to use this as quality control or internal quality control.
Yeah, absolutely. Thank you. Also, we have been asked what, and perhaps you know, what is the reference value for MRD for the B cell ALL?
The reference, this I probably don't understand correctly. The reference for the B cell?
What's the reference value for MRD for B cell ALL?
Okay, so this is more or less the same question to the sensitivity level.
Yeah.
This depends on the assay you use and the number of cells. So if you follow the Euroflow panels, you should at least have a sensitivity of 10 to the minus 4 and a little bit below. If you have your own panel or other combinations, or you just change the colors, and this is, I think, quite important. If you think, well, the Euroflow panel looks quite nice, but I rather use brilliant violet colors or dyes, than the published ones, then you change the assay and the sensitivity level or reference level will change, and you have to assess it by your own.
Okay. Also, so we're getting questions around many different markers, obviously. So we have one around CD123. And if you can give us any further information to distinguish between hematogone and residual blast. And can this give us further information?
Well, I think it works, at least in the early time points, it works quite well. The problem is that it is often rather weakly expressed, and so you need it at least in a quite bright color. But I think it's a valuable marker, and I like it a lot. It's always a question whether you like the combination as it is in the Euroflow panel together with 66C. I think you have to get used to it, or whether you have whether you use it in a single stain. And I think it's comparable to CD66C. That most of the cases have a combined expression. And more or less it's comparable, and you can take either one.
Okay. Also, so we're getting a question that's a bit more extending the topic. So in the era of immunotherapy, anti-CD19 therapy was blinatumomab. I'll take this again. So in the era of immunotherapy, we have the anti-CD19 therapy was blinatumomab. And what do you think are the other better primary gating markers for the MRD assessment?
That's probably the most difficult answer, and there's no perfect answer to this, because the biggest problem is that most patients who go on to blind treatment or further treatment are quite problematic cases, and they not only get blinatumomab, they also get anti-CD22 treatments or other bites, and so you lose more and more anchor markers, not only CD19, and it's very difficult to find a better substitute than CD19, and I think this answer is not yet given.
Yeah.
CD22 might be one option, 24 maybe, and others are discussed, but I think we do not have enough information on stability during the treatment and influenced by CD19 targeted treatment on the other markers. So we need I think at least a few months time to assess this more into detail.
Great. And also, so more specifically back to one of your slides where you were comparing the different techniques. You also showed so that the flow-based MRD is applicable in 95% of cases compared to 90% by PCR. And I see that someone wanted further comments on that. I'm guessing it's probably around why you're saying 95 and 90 to PCR, but I'm just guessing this is why this question is coming in.
Yeah, well, this was a table I adapted from a publication from Campana.
Okay.
In 2010, and this was published there. It always depends on the patients you analyze, but I think around 90% is for PCR-based targets, plus minus a few percent a good value. If you take into account that you want to reach a sensitivity of 10 to the minus 4. And with flow cytometry, I think, and this is also depending on the panel you use, 90 to 95%, it's quite reasonable as well. Although with the new treatment techniques, you're fully right, this might decrease to lower values, especially if you use CD19 or CD22 targeted treatments.
Okay, thank you for clarifying this. So also back to the markers. So we've also been asked, can CD38 discriminate between the leukemic cells, hematoglobins and plasma cells? And someone's commenting and saying, well, it might be depending on the brightness of the expression. What's your view on this?
Yeah, that's a very good one. Definitely on plasma cells, CD38 is quite high expressed, very high expressed, and usually it separates nicely. And with blasts, I think you need to compare this with the initial immunophenotype. So this definitely helps because not all of the ALLs shows quite very distant CD38 expression. But at least from my perspective, it helps in combination, at least in combination with CD10 and CD20 and CD45 expression to get an impression whether this is a reactive B-cell precursor or a malignant blast.
Thank you. So we're getting many questions coming in, so we won't have the time to answer all of them, but I might just take one last one, because I think you've been with us quite a long time and you might need also a rest, because I feel like you're getting a lot of, it's quite intense here. Perhaps, so on the last one, we've been asked, can you assess MRD without the diagnostic sample immunophenotype, excuse me?
Again, a very good question. Well, I think there are cases where you clearly can say this is a malignant blast population. It's easier in early time points and more difficult in later time points, for sure. But the numbers of cases where you are not comfortable with stating a clear-cut diagnosis, it's growing if you don't know the initial immunophenotypes. So we receive more and more samples without having the initial immunophenotype, and it's difficult, I think. I would rather like to have it, at least by example, the written report, so that you at least know which kind of ALL it is, whether it's a common or Pro-V and so on. But if it's difficult, I just say it's not possible without having the initial immunophenotype to compare.
Great. So that was my last question to you, because I have been bombarding you with questions. But I think it's very nice to see that your presentation has raised many questions. I think this also shows that people have appreciated it. And I wanted to thank you for giving this great presentation. And also wanted to thank all the people who have attended this presentation. It's been great having you, and also seeing all the questions that have been coming in. Dr. Ritgen, I don't know if you want to add maybe something before we end the webinar.
Well, it was a pleasure to me to give this webinar, and if anybody has further questions, feel free to contact me. Well, if you really say there are so many questions, I will probably need some time to answer all of them. So if you don't expect an immediate answer, don't hesitate to contact me. And it was a pleasure to give the talk, and maybe we see each other again in another webinar.
Thank you, Dr. Ritgen. Yeah, there were many questions around how many cells, how do you get to this high number of cells, what do you do if you don't get to this number of cells? So I think it might be, yeah, you're getting people contacting you regarding this, but I'm guessing that, as you said, this was the challenge in setting up this this method. So probably you can give people a few tips also.
Okay.
Thank you very much, and thank you everybody for joining. Have a nice end to the day, or perhaps start to the day, depending on where you're joining us from. Thank you very much, and bye-bye.
You're welcome. Thank you very much. Bye-bye.